Oh, I haven't.
Let me find the slides.
So I think we're live now. And so I think because we can give it a few minutes just to make sure a few other people join.
Okay, close that. There we go. Then share my screen. Okay, I think that's it. Okay, is that showing up?
Yeah, it's looking good.
Sorry, that was a bit of a chore there. Yeah. There you go. Okay. Cool. Hello, good evening. Thank you for tuning in. Apologies for that slight. That was just us trying to get the technology to work. I'm Aaron, and this is Alex. We're a couple of F1s here to give you some teaching this evening on urology. It'll just be 10 quick fire, high yield teaching bits and bobs. On 10 topics. Just whilst you wait for people to connect, I'll just, if you could scan the QR code if you haven't already, and just fill in, I think it's a short survey regarding one of the research things that we're trying to run this year. It should only take a couple of minutes of your time, and then we'll get started at about 5 minutes past 7. Yeah. Yeah. Cool. Controls work. Yeah. To be honest, shall we just get started?
Yep.
Alrighty. I'll let Alex do the first couple of questions, and then I'll take over for the end. All right.
Okay. Yeah. So as we said earlier, we're going to cover urology in this lecture. We have put up there the different topics that we cover. So without further ado, we can go on to the first question. So we'll give you a few minutes to read the question and answer it, and we'll put a poll up as well, just so you can sort of see how your answer, sort of how you do compared to other people. So feel free to move on to the answer slide, Aaron, when... Okay, so in this first question, essentially the diagnosis you should have recognised as acute urinary retention. And then from that, the immediate management would be to insert a urinary catheter. Sort of the way you could discern that the patient was in acute urinary retention, so a bit about the history, so the fact that they were in abdominal discomfort and weren't able to pass urine, but then the bladder scan showing 500 millilitres is quite a lot. And then looking at potentially some of the reasons he might be in urinary retention, which we will go through in the next few slides, sort of how to systematically assess a patient for urinary retention and possible causes. But essentially this patient had a GA, so anesthetic drugs are a risk factor for urinary retention. They were also sort of like displaying some other symptoms of urinary retention, such as sort of becoming a bit more delirious as well, and the abdominal discomfort, of course. So if we move on to the next slide, we'll talk a little bit about urinary retention. So it's the inability to voluntarily empty the bladder. It can be acute and chronic. So that this patient, it was acute. In terms of thinking about causes, so the obstructive ones, usually the more common ones, and can be either chronic or acute, usually chronic leading into acute retention. So your prostate enlarging either through benign hyperplasia or prostatic cancer. You can have urethral strictures caused by UTIs. You can have blood clots within the urethra. Also stones, severe constipation, another cause of obstructive, tumours, and then organ prolapses. Thinking about cystocils in females. So medications are another cause, and these are more likely to be acute causes of retention. So your opioids, different anaesthetic agents, and your anticholinergics. And then just thinking a bit more out there with causes, so neurological causes such as spinal cord pathology, diabetes, and also there could be a psychological element to urinary retention. So thinking about some of the symptoms, so, of course, like you might be just completely unable to empty your bladder or start a urinary stream. But you also might have some sort of, especially in chronic retention, some more less severe symptoms such as dribble, weak stream that can cause to, even though you're passing some urine, you are retaining a lot of urine as well. Recurrent UTIs, so this is sort of like a bit of a chicken and egg situation. So the UTIs could cause the obstruction, but then sort of the urine festering with it, or like within the bladder, can fester different bacteria that can again lead to UTIs. Of course, abdominal discomfort. And then when you come to assessing the patient, so the examination is key to try and attain if this is new, acute, chronic, different precipitating factors. In terms of the examination, there won't be any significant sort of like physical findings apart from potentially the abdominal tenderness. You would do a PR exam in a guy to assess the prostate, and we come on to some of the findings you might have there a bit later on. PSA in a male, and again we'll come on to the uses of that and when it is potentially not as useful. UNEs, because obviously you could get hydronephrosis, so kidney impairment, so backflow of urine into the kidneys. Bladder scan, really useful for actually diagnosing urinary retention. And then urine analysis, looking for stuff like blood, looking for infective markers, and then more sort of secondary investigations like urodynamic studies and cystograms. Not going to be something you do in the first instance. We spoke a bit about the complications, UTIs, but hydronephrosis is a really key one. So treatment, so if it's acute, you're always going to insert a urinary catheter. In chronic, ultimately they can be treated with a urinary catheter, but that's not going to be a long-term solution. You can have long-term catheters, but it's not going to cure the issue. It just treats it. So obviously thinking about treatments for the causes, so benign prostatic hyperplasia treatments, different surgeries for organ prolapse, urethral strictures, reviewing medications, and then different lifestyles, and like urinary habits. So you can sort of do certain exercises to start sort of training the bladder. So I'll let you read and answer question 2 now. Okay, should we go on to the answer slide? Okay, so hopefully you realise that the patient had benign prostatic hyperplasia, and that initiating treatment was necessary in this case. So if we go on to the next slide, we talk a bit about PPH. Oh, sorry. So this is just a follow-up question from that. So I think if we answer this, and then we can talk about BPH overall. Okay, so do you want to go on to the answer slide? Okay, so it will probably be quite useful just to go through some of these answers to say why they are right and wrong. So say this patient was started on tamsulosin for benign prostatic hyperplasia. So the first point, so A, increased risk of prostate cancer. So that's not true. There's no link between BPH and that being a risk factor for prostate cancer. UNEs being monitored routinely, not necessarily routinely. If there's no signs of retention, then there wouldn't, and tamsulosin isn't really associated with any kidney impairment. So unless the patient has maybe underlying kidney issues where you would consider monitoring the UNEs, but not routinely, especially in this patient. So tamsulosin increases the risk of falls through postural hypertension. So because it's a muscle relaxant, it also relaxes sort of vasodilator now as an alpha-1 agonist. So it also increases the risk of falls through postural hypertension. So that's just an important point that you would want to mention to the patient when you're counselling them on starting medication. Tamsulosin medication. Being of Caucasian ethnicity is not as high risk of developing BPH as being of Black African ethnicity. Again, like, even if that point was the other way, if answer D was the other way around, I'm not sure if it would be a relevant point to bring up to a patient. And then tamsulosin increasing the risk of gynecomastia isn't true. There are some hormone therapies with prostate cancer that can increase the risk of gynecomastia, but not tamsulosin. So I think if we go on to the next slide. So just talking about benign prostate hyperplasia. So as we said, non-cancerous, usually sort of presents as these LUTS symptoms that we're sort of go over now. So you have sort of obstructive symptoms similar to the retention. Always important to ask about these in the history, and then like irritative. So this is sort of like increased urgency, frequency. So almost like overactive bladder sort of symptoms that can be caused through the enlarged prostate. And then sort of thinking about like complications you might develop. So if you're in a bit of sort of retention, so you might increase the risk of UTIs. Also through that, the risk of bladder stones and kidney damage through hydronephrosis, sort of all linked to the retention topic we've been speaking about. And then the point there as well about sort of being Black African ethnicity being at higher risk than Caucasian or Asian. In the next slide. Investigation. So there's sort of a questionnaire that you can do for patients just to ascertain the impact that LUTs will have on LUTs have on their life, and this can direct you into the most appropriate treatment if they need treatment, medication, or potentially further treatment, sort of like surgeries as well. DRE is important. So for BPH, it's going to be enlarged but smooth. So urine analysis, again, looking for blood infection, other causes of the LUTs other than just BPH. Sort of depends on the hospital, sort of the setting, but if you're in a hospital, you might consider a post-void bladder scan to assess the amount of retention. PSA, so this would be more like a screening test, and it's non-specific, but if it's raised, it's quite sensitive to prostate cancer, sort of meaning that there's different causes of a raised PSA, but if you have if you have prostate cancer, it would most likely be raised. So it's more of a screening test, and you would want to cancel patients when you're taking that. UNEs, again, always a key one to get in there. And then cystoscopy, potentially, especially if sort of first-line treatments haven't worked. So sort of going off the questionnaire, the IPSS questionnaire, you could consider just watchful waiting if the LUTs doesn't have a huge impact on their life. Then usually first-line medication is tamsulosin, so the alpha-1 blocker. So it relaxes the prostate and urethral muscles, like in theory, reducing the LUTs through that mechanism. And because it's an alpha-1 blocker, It also sort of causes vasodilation, and that's where the postural hypertension, increased risk of falls, came into it in the previous question. So 5-alpha reductase, so such as finasteride, again shrinks the prostate, so hopefully relieving some of the symptoms. And then once you usually start them on tamsulosin, and then you'd add on finasteride. If they have overactive bladder symptoms, you could consider an anticholinergic agent. And especially if they have more severe symptoms which aren't amenable to medication, so you could consider a TARP, so transurethral resection of the prostate. And a key complication that isn't as common now, but maybe might be more common in exams, is TARP syndrome, which presents as agitation and confusion. It's essentially fluid overload and hyponatremia that has to be very carefully managed due to the risk of neurological complications. So let you read and answer question 4. Okay, should we go on to the answer third? Okay, so essentially the most important initial investigation in a highly suspected prostate cancer is an MRI scan. So yes, PSA is an investigation that you will do. However, as we just spoke about, it is non-specific. So even if it's raised, there are other things that might raise it. So it's important for that not to just be like the only factor that you're going to go off when you're sort of thinking about, obviously, like further investigations to physically diagnose, like to actually get to the diagnosis for the patient. So abdominal ultrasound, just go back. Yeah. So abdominal ultrasound, yeah, it's a useful investigation, but not in this case. For visualizing the prostate, MRI is much more useful, and in terms of your differential diagnosis, because prostate cancer is so much higher up there rather than any other abdominal pathology, you wouldn't opt for the ultrasound as one of the first investigations. And then the 2 biopsies, so that's for your actual diagnosing and state and sort of grading cancers. We'll come on to that in a second. But yeah, just in key factors, that MRI is the most important first investigation. So if we go on to the next question, to the next slide. So this is sort of a follow-up from prostate cancer. So would you let you just answer this and then talk about prostate cancer overall? if you want to go on to the answer slide. Okay, so lumbar spine, most common location for prostate cancer mets. So if we go on to the next slide, talk about prostate cancer a little bit here. So commonest cancer in men, elderly men especially, are the ones who sort of it affects the most. It's an adenocarcinoma, usually within the peripheral zone of the prostate. In terms of MET, so it's usually the spine, so it spreads the bones really. So spine and then lumbar, thoracic and cervical spine. Also can spread to the lymph nodes. Androgen dependent, which is important when we come on to thinking about some of the treatments. And then risk factors, apart from the obvious, such as age and sort of family history. And within the family history, you can think about BRCA. So patients with especially BRCA2 are increased risk. And then Black, African, Caribbean in terms of ethnicity. Presentation, so patients might have LUTS, but because it's usually present in the peripheral zone of the prostate, they might just be asymptomatic until they present with quite late sort of symptoms of advanced disease. So initial investigations, if you're suspecting prostate cancer, so you're going to do a DRE, it's going to be craggy, asymmetrical, quite firm, as opposed to like the smooth texture to benign prostate hyperplasia. So PSA you will do, but again, just realise that it's not specific. And then, so the MRI is what you're going to do when you really are suspecting it. And there's the Likert scale, which grades the MRI to sort of from 1 to 5, depending on your suspicion. And that will dictate if you're going to do a biopsy. And the biopsy is essentially there to diagnose and grade the cancer. So usually you do transperineal, because of the lower risk of infection. It's ultrasound guided. And so then you have the Glenson grading. So you can see on the right hand side here. So it's 1 to 5 for sort of like how differentiated the cells are. And essentially there's 2 numbers. And they add them together, so it's a score out of 5, and that will sort of give you like a cancer risk. And then you'd also consider further staging, such as CT staging and bone scans, essentially looking for metastases, specifically within the bones. So next slide. So use the TNM for staging. So it's something which it's probably quite important to sort of like have an understanding of. It's one of these things, like if you want to try and commit it to memory, then you can. Obviously, there's lots of different TNM stages for different cancers. It probably is sort of something to just sort of have an understanding of. That T1, it might be too small to sort of feel on exam or see on scans. 2 within the prostate, 3 extends outside, and then 4 to the nearby organs. And then N1 as if it's 1 or more node, and then M2 if it's metastasized. Thinking about treatment, so if it's early stages, you can perform a radical prostatectomy, removing the whole prostate. However, as we spoke about earlier, usually most prostate cancers present a bit later, so wouldn't be amenable to surgery. Radiotherapy is one of the mainstay treatments, so you can do external beam radiotherapy or brachytherapy, where you insert radioactive seeds within the prostate, and it's sort of a prolonged sort of delivery of the radiotherapy. And proctitis is one of the side effects that you'd get from all sort of complications that would lead to lots of sort of side effects for these patients. Hormone therapy, again, so all with the aim of reducing androgens, because essentially that's one of the driving factors for developing and advancing prostate cancer. So you have your androgen receptor blockers and your GnRH agonists, and that sort of you have to cancel them a little bit on risk factors there. So erectile dysfunction, osteoporosis, fatigue, potentially the risk of gynecomastia as well. And then chemotherapy is an option, but really only if it's sort of metastatic disease. Okay, so I think that's the end of prostate cancer. So I'll hand you over to Aaron now to do the second half of the questions and slides.
Well, thanks, Alex. So question 6. I'll give you a couple of minutes to have a read, and the poll should pop up. Already. So with this patient, you're wanting to, given the history and the examination finding, wanting to try and get the urology team to come and have a look with and you will probably want to counsel the patient that they're probably going to take in the theatre for an urgent exploration of the testicular region. Now, why is this the case? So they probably have what we call testicular torsion. Now, whilst imaging is useful, if you're highly suspicious of a torsion, you would make that diagnosis based off of your examination and the history. Some kind of indicators, there can be a traumatic or high energy impact. However, sometimes there is a patient population that is predisposed to recurrent torsion events. If you do take them to ultrasound or scanning of some sort, and if you were to get an ultrasound testes, you would see what they call a whirlpool sign. So if you look on the right-hand side on that image, I can kind of convince you that there's a kind of whirl effect that you can see, and that's apparently what you would see if you have a quite severe torsion. However, based on presentation, you're going to find a unilaterally swollen and possibly horizontal testes on the affected side. I've not tended to find that patients will let you examine, but if you were able to do a physical examination, classically it'd be really swollen and possibly horizontal. Again, you would also lose the cremasteric reflex, which is when you stroke the ipsilateral thigh. There should be a visible rise in the testes. Again, I've not been able to perform that clinically in real life because the patient's normally in a lot of pain and is normally just lying in bed. So, but you will find big nausea and quite a lot of vomiting. Perhaps you'd want to initially get them lots of pain relief and try and get urology to take them to theatre rather urgently. Another thing so painful testes can happen in GP, it can happen in A&E, and you need to be able to distinguish between true torsion and epididymitis. So one of the ways that we can distinguish that and possibly reassure the patient is in epididymitis. You can get a friend's sign where if you elevate the affected testicle, you should get a reduction in that pain. Whereas in torsion, because the testicle has twisted upon itself, if you were able to raise that testicle, the patient would still be in quite a lot of pain. And the definitive management for this is an urgent surgical exploration, because then they can untwist it, and they can perform surgical interventions like pinning or stitching the testicle to the testes to the testicle so it doesn't twist. If that makes sense. All right, question 7. I'll give you a couple minutes to read that, and I'll put the poll on. Okay. So the GPs probably prescribed them a brand new medication, and as part of that, you need to, when you start any patient on the new medication, you need to counsel them on the likely side effects. Okay, so the key side effect that they might experience is a drop in blood pressure, or what we call postural hypotension. However, I just thought I'd translate that into what you would actually tell the patient about. So what this patient is probably complaining of is erectile dysfunction, which is defined as the inability to achieve or maintain a sufficient erection for sexual performance. This can be very frustrating for the patient, and one of the key things that you need to differentiate or think about is what's actually causing it. So it can be, hence taking a clear clinical history is really good. So in terms of ruling out things, other causes such as physiological dysfunction, they could be on medications that have side effects of erectile dysfunction, or they could have genuine pathology. So they could have previous injury, or quite commonly if they've got vascular disease or diabetes. It can also be a complication of the things I've listed above. So in terms of the management options for erectile dysfunction, once you've pinned down the cause, you can have options like just talking therapies or psychosexual therapies for those who need a bit of psychological support, as this can cause quite a strain on people's relationships, which can lead to a cycle of erectile dysfunction, and then the relationship doesn't function as well, so then they have it just loops essentially. However, on the medication front, you can prescribe oral phosphodiesterase inhibitors. Examples of this are sildenafil. I think the trade name is Viagra or Cialis. Note now that patients can get it from the GP, but they can also get it over the counter. So you might get people with these side effects, and they might not be on their GP records. More in terms of if that fails, you can get more mechanical and surgical interventions. So a vacuum aid is literally just a vacuum that sucks the blood into the corpus cavernosum. You can have intracavernosal injections, which again inject. I think it's a gel. I'm trying to remember my time in the urology clinics, and then you can also have implantable prostheses, which have effectively a valve that can fill in and out of either saline or the gel to induce and maintain the erection. But our first line is or our main treatments would be psychosexual therapies, or if they're amenable to it, an oral phosphodiesterase inhibitor, or Okay, so we'll go on to question 8, and I'll give you a couple of minutes. Okay, just for Paul, question 7, the answer was blood pressure drops as what you would need to counsel the patient on if you were starting them on a phosphodiesterase inhibitor. For question 8, the correct answer is an urgent 2-week wait to urology referral. So the reason I've put this is essentially sometimes in a PSA they like to specify specifically where you are in terms of, and that really affects what kind of investigations and tests you can request. So in the GP, you're rather limited on where you can go for when you need urgent tests. So whilst the signs and symptoms for this patient were pointing towards a testicular cancer, the GP probably isn't the best place to send off and start these investigations, whereas the NICE guidelines say that an urgent 2-week wait urology referral is the way to go, because when you make that referral, they're then under urology, you can organize the specific and the correct tests, as well as getting the results for those tests back to them so that they can, the urology team, get the results back and connect on them in a much more timely manner. Whereas if you, I'm sure we've all been on GP where bloods take a couple of weeks to get back, and then by that time the patient's moved on or they no longer have the symptom. So testicular cancer, it's the most common solid cancer in young men, aged 20 to 45. You've got a couple of differential diagnoses. Again, it's just the differentials are just pathology in the testicles. But the specific criteria is a painless testicular lump with a change in size and or texture is what warrants a 2-week wait. I think NICE guidelines specifically say that you could also consider doing these blood tests when you make that referral. However, if they're not done at the time of being seen in the primary healthcare setting, they will be done in the initial workup. In terms of relevant imaging, you can get an ultrasound testes or a CT tap if you're suspecting a metastasis. So speaking about metastasis, the most common sites, so if you the way I like to think about this is from the testes, it spreads via the lymphatic drainage, and so one of the most common sites is actually the para-aortic lymph nodes, because it drains directly, or the lymph nodes that the testes drain into are really close to the aortic, into the aorta. And then tracking upwards, then they can then go into the lymph nodes of the lungs, the liver, the bones, and the brain. However, they tend to ascend in a stepwise manner. So you typically get your para-aortic. I think I've read it from if it's a left-sided testicular cancer. However, I'm sure if you have metastases and have metastases, but classically, I think it's a left-sided testicular cancer that spreads to the para-aortic lymph nodes first, and then goes into the lungs and liver. Alright, final couple of questions. Question 9, I'll give you a couple of minutes to answer that. Alrighty, so with this question, this patient has a varicocele, which is it's just defined as a visible or palpable enlargement of the scrotal veins. In your exams or in the urologies, you might have it described as a bag of worms appearance. However, I don't want to just say bag of worms, because people tend to learn the association and not the actual examination findings. The pathophysiology is relatively similar to varicose veins, where there's an insufficiency of the valves within the testicular drains, in the testicular veins, and so blood has backflow blood down into the veins, supplying the testicles. Of note, there's a clinical finding where if you get a left-sided varicocele, I think I mentioned this last week, where on the renal session, but a left-sided varicocele can be associated with a compressive cause, which can be caused by a left renal cancer, where the left, where the if there's a mass or a blockage in the pathway of the left renal vein, it can compress the drainage of the left spermatic vein, causing that left-sided varicocele. In terms of the management, you tend to be a bit more conservative with this one, counting the patient that will watch and wait and see if it goes away. However, if it doesn't go away or starts to be painful, or if it starts to grow, so change in increasing pain and the functional effect on the patient are your treatment triggers, essentially. You can embolize the scrotal veins, or you can have surgical repair of the veins themselves. All right. Final question. Okay. And I will hope this comes up. There we go. Yes. And I'll put on the poll. Okay, so from that one, that X-ray shows a Staghorn calculi, and with the signs and symptoms that the patient is presenting with, they've probably got Staghorn calculi and renal stones. All right, so yeah, so kidney stones, they're stones in the urinary tract and all the kidneys. They present with renal colic and or frank hematuria or dysuria, oliguria, or anuria if the blockage is severe enough. The NICE guidelines specifically say that initially, just depending on the size, is what affects the management. So if it's you're going down the conservative management route, it's NSAIDs, escalate into IV paracetamol and opioids if NSAIDs are initially unsuccessful in controlling the pain. You tend to go for watchful waiting for asymptomatic stones that are less than 5 millimeter. It's kind of a hard one to counsel the patient on, because you're essentially telling them that we're just going to wait for them to pee it out. However, if it's above 5 millimeters, if you appropriately safety net them, you can also just watch and wait and prescribe them a good amount of analgesia. So in terms of if the renal stones are above 5 millimeters and the patient doesn't want to watch and wait, which is understandable, the table on the right has the exact criteria. I'm not going to read it. I'm sure you don't want me to go through all of them, but for this specific question, the renal stone in question was definitely larger than 20 millimeters, and it is a Staghorn stone, as you can see on the X-ray. And so the treatment options are a percutaneous nephrolithotomy, or a uteroscopy. So a PCNL is essentially where they go in through the skin into the kidney to try and get rid of, and to make an incision, and they try and get rid of the stone from inside the kidney through the skin. Whereas URS or uteroscopy is where they take a camera or an endoscope all the way up the urethra into the kidney itself and try and dislodge the stone that way. The NICE guidelines regarding treatment of kidney stones is quite high yield, because they can give you specific sizes and symptoms, and they can ask you what's the most appropriate treatment. All right. Yeah. Okay. I think that's all the questions. If anybody has any questions, we'll just be hanging around for a couple of minutes. But if not, thank you so much. Try and enjoy this lovely sunny day in North Yorkshire. So it's really lovely. Have a good one. We'll stay on for a couple of minutes.